welcome to our usual Thursday quiz, which is being held on Wednesday. This is Pancreatic Cancer Month, so all of the cases, I think there's about a dozen, will be pancreas. So let's get started. This was an incidental finding. There's a cystic lesion in the body of the pancreas with a mildly dilated pancreatic duct and focal calcification. Incidental note is made of fatty infiltration of the liver. On the 3D maps, you can see the lesion is very well defined. It's kind of low density for an adenocarcinoma, but I guess you would still have to consider it. What else causes pancreatic duct dilatation? Theoretically, a mucinocystic neoplasm or NCN, or even a serous tumor, they commonly will have calcification. Here's the lesion again on a few additional 3D images. So I'm focusing the calcifications, maybe serous cystadenoma. Neuroendocrine tumors can calcify, but this is really low density. I just can't think about this being a neuroendocrine tumor. And again, a bunch of more images. What do you think? Serous cystadenoma. People often say serous cystadenomas don't have duct dilatation. That's not the case, and this was a good example. Again, calcifications were helpful. Weight loss. We see, interestingly, what looks like a mass in the duodenum right here. There's also a dilated common duct. And when you start looking, maybe I'm dealing with a duodenal carcinoma, but then as we come a bit more forward, take a look at the common duct and take a look at the pancreatic duct, but especially on this image, really nicely shown coronal, dilated common duct, and here's the obstructing mass. This could be an ampullary lesion. You would surely worry that this is a malignancy. Not every ampullary lesion is malignant, but I would worry about that. Or it could be a duodenal cancer invading the ampulla. Here's a few more images showing that very nicely. Here's a few additional images showing the mass, how it's really within the bowel proper. Again, a few more images. You can see by the number of images I'm showing, I really like this case, which was an adenocarcinoma arising from an ampullary adenoma. It was obstructing and invading the common duct and the pancreatic duct. A really nice case. Another case, cystic lesion head of pancreas. There's some septations or soft tissue density superiorly. It's not a simple IPMN. If it is an IPMN, you would worry that it could be moderate or even high-grade dysplasia. Could be an MCN, not the best location. Doesn't quite look like a serous cystadenoma. Not a great location for an MCN. But it could very well be an MCN, though we like those more in the body of the pancreas, typically 40-ish-year-old women. Could this be a serous cystadenoma? I guess it's a possibility. Here's the look on the cinematic. And again, you're focusing on the cystic nature of the lesion, that soft tissue component, and this was an IPMN. Fortunately for the patient, there was no dysplasia. So a benign lesion. Another case, you see a hemangioma in the liver. That's an incidental finding. But then you see a dilated pancreatic duct, atrophy of the body and tail of the pancreas. And again, you're seeing here nicely on the coronal on the left, a double duct sign. Dilated common duct and dilated pancreatic duct. There's no large tumor, but there is something going on by the head of the pancreas. Like I showed you before, when you have a dilated common duct and pancreatic duct, you have to worry. Double duct sign, ampullary tumor, a mass in the head of the pancreas, even a mass in the common duct secondarily involving the pancreatic duct. The liver lesion is just an incidental hemangioma of no significance. Image on your right nicely showing you the double duct sign. And then as we look through all the images, this was again an ampullary adenoma with high-grade dysplasia. Not a carcinoma. For us, it's hard to tell that. That's a pathologic diagnosis. It's better to have high-grade dysplasia than a carcinoma, obviously. Patient had a Whipple's procedure and should do very well. 40-ish-year-old female, mass and tail of pancreas, rim-like calcification. Could be a serous cystadenoma. Could be an MCN. I don't like it for a neuroendocrine tumor. Another lesion that gives very coarse calcifications, like this one does, as shown in the MIP imaging, is a SPEN, a solitary papillary epithelial neoplasm, more common by 9-to-1 in women than men. Usually it's women in their teens or 20s, but we've seen them 40s, 50s, and 60s, and even in their 70s. Old hematoma, I'm thinking about, this is calcifications in a mass, and I'm going to favor a SPEN tumor. I would consider neuroendocrine, but again, it's not vascular. MCNs can calcify, and it's not a bad location. MCNs usually more body than tail, but it's close enough. Again, a few more images. And what did this end up being? This ended up being a SPEN tumor. Again, it's important to work through the processes, the findings, the ducts, the presence of calcification when you analyze pancreatic lesions. And you can see I'm not showing you adenocarcinoma. I'm showing you more the spectrum of what we can expect to see with pancreatic lesions. Another case, complex cystic lesion, head of pancreas, no real duct dilatation, neither common nor pancreatic duct. There's some stretching of the GDA. What are we dealing with? Vessel is stretched, no invasion. On venous, the cystic nature of the lesion is better seen. This is a good example and one of many of serous cystadenomas. Again, serous cystadenomas can be solid, they can be oligocystic, they can have some septations, they can be multicystic, lots of appearances. Here's a patient with a lesion in the liver and in the body of the pancreas. When I look at this, and these are my only images, I have to say this is a neuroendocrine tumor. But as we scan further down, we see that the patient is missing the left kidney. So neuroendocrine, liver mets is a good thought. But when you see a missing kidney, you got to be thinking metastatic renal cell carcinoma, typically clear cell to the pancreas and to the liver. Just a really, really nice example. Here's the vessels, nice illustration of the celiac and SMA with cinematic rendering. Just a really good case. Okay? Really nice example. Incidental finding, tail of pancreas, high density. This could be a splenule, I would think about that. It could be a neuroendocrine tumor because they're both high density. Sometimes it's a challenge to determine whether something's a splenule or a neuroendocrine tumor. Usually if the pancreas is having the lesion and the spleen is present, you compare the two. If it's a splenule, it enhances exactly like the spleen. If the spleen's gone, well, then maybe it's more likely a splenule because you have splenosis, but it can be somewhat challenging. Usually we can make the diagnosis. Nuke scans can be helpful at times. There's the lesion. This was a serous cystadenoma. Remember, I mentioned serous cystadenomas can be solid. When they're solid, they look like a neuroendocrine tumor. Just a really difficult case. Very interesting. Abdominal pain, another lesion, body of pancreas. Hypervascular, abutting the celiac and the SMA. You could think of a serous cystadenoma solid type, but most commonly, again, we can think of metastatic renal, but we'll assume the kidneys are there. I have to be thinking about a neuroendocrine tumor. And guess what? I was wrong. It was a solid variant serous cystadenoma. We've just written an article about that. We're working with AI. We're working with cinematic rendering because it's a real challenge, these serous cystadenomas that are solid. Fortunately, they only make up about 3% of serous cystadenomas. Incidental lesion, tail of pancreas, near body-tail junction. Not very vascular, somewhat cystic, no dilated pancreatic duct. The lesion is somewhat eccentric. Could be an MCN, good location if the patient's in their 40s. Serous cystadenoma, I don't know, it doesn't really, I don't like it for that. Doesn't look like an adenocarcinoma because those are more infiltrating and you see a dilated duct. There's some soft tissue density there. MCN with high-grade dysplasia would be a thought. Here it is on cinematic rendering. The soft tissue component is better seen on the cinematic rendering, really nicely shown here. And here on the off-axis views. And this was a neuroendocrine tumor. Just a really nice example. Another case, cystic lesion, head of pancreas, rim-like enhancement. When I see an enhancing lesion with rim enhancement, I'm always thinking of neuroendocrine tumors. I could also be thinking about metastasis, but it's not going to be adenocarcinoma. It's not the look of an MCN or serous cystadenoma. And again, neuroendocrine tumors can be small, they can be incidental, they can be functioning, but most of them are going to be incidental findings. Like in this case, there is some atrophy of the distal body and tail of the pancreas. This was eventually biopsied and removed and was a neuroendocrine tumor. So a classic example. Incidental finding, cystic lesion. You're not even sure where it is. Is it a mesenteric cyst or is it off the pancreas? When you look at all of the images, it's abutting the pancreas. Now, you still could say mesenteric cyst simply pushing on the pancreas. When I see a lesion very close to the pancreas coming off the gland, like this one seems to do, I always think about lymphatic cysts. Again, you think of lymphangiomas, you think of mesenteric cysts. But here it is coming off the gland, and it looks like it's attached to the gland. It can be tricky. This is a benign lesion. If you know what it is, it's a leave-alone lesion. If you biopsy it, these patients often get really bad post-procedural pancreatitis. Here it is in 3D imaging. A really nice example of a lymphoepithelial cyst. Another one, cystic lesion, tail of pancreas, thickened wall, no septations, no nodularity. Could be a cystic neuroendocrine tumor. Could be an IPMN with dysplasia. Could be a serous cystadenoma. Could be an MCN. It doesn't look like a simple pseudocyst. There's enhancing rim. When I see enhancing rim, it always pushes me to a neuroendocrine tumor. I don't see liver mets. I don't see other lesions. You can see the wall of the lesion nicely, particularly on the cinematic rendering images. So what do you got? You got an MCN. Again, good location. Patient was in their 40s, hopefully, more likely a female. But a cystic neuroendocrine tumor would be a good bet. MCNs are considered malignant or pre-malignant, and they'll always be resected. So with that, I've shown you a bunch of great cases. Pancreas Month, we are working hard trying to detect pancreatic cancer early, working with the Lustgarten Foundation, working with Microsoft. We're working hard, and I think we're making progress. So with that, have a great day, everybody.